So the title of my talk is how we work up uveal melanoma. So my talk is really aimed at patients and carers and family of patients with melanoma and those involved on the more primary care side. So I'm going to try to put myself in the place of the patient as they try to navigate this very challenging experience of being diagnosed and managed with uveal melanoma. In an ideal world, the ophthalmologist would be the first and only medical practitioner encountered by patients with uveal melanoma. We would have these patients referred to us early on when the tumour's small and treatable and never has a chance to metastasize, and we would never need to involve oncologists such as Anthony and his colleagues. I think this was made starkly clear in Anne's presentation this morning. We have to find these tumours earlier. So just to put this in perspective, so I work in Perth in Western Australia. For the non-Australians in the audience, Western Australia occupies the western third of the continent. We're known for our great weather, our beautiful beaches and our friendly locals. But we're just a small centre in the most geographically isolated city in the world, with a population of less than 3 million throughout the States. We currently have just one ocular oncologist serving this population. So what I'm going to say may not reflect the patient experience in larger centres with more resources and specialist services. Nevertheless, I'm sure many of the same principles hold. So my role as an ocular oncologist centres around 4 main clinical areas: diagnosis, treatment, prognostic testing, which has already really been covered by Svetlana and others, and follow-up. So I'll concentrate mainly on diagnosis and treatment. So the first question, often unspoken from patients, is, why am I here at all? So patients are often asymptomatic. They don't have symptoms. The majority of my patients are referred after a screening examination by an optometrist, or a fellow ophthalmologist has discovered an abnormal fundus finding. So I would, at this point, like to acknowledge the pivotal role that optometrists play in detecting these cases early. It's only by detecting cases while they're small and treatable that we can, I think, impactfully improve survival from what is potentially a fatal disease. So when we're talking about ocular melanomas, and Svetlana has covered this much more nicely, we're largely talking about uveal melanomas. That is, tumours of the iris, ciliary body, and mainly the choroid. Conjunctival and eyelid melanomas, they're a different category with different embryological origin. So I won't discuss those. This talk just applies to uveal melanomas. And an often a question I'm often asked: how can I have a melanoma in my eye? Patients are genuinely surprised. So, and the reason, of course, is that you can get a melanoma in any tissue or organ in which there are melanocytes, these pigment-producing cells. So these are present in the skin and the mucous membranes, but they're also present in large numbers throughout the uveal tract, which is the pigmented layer lying between the sclera and the retina. So the melanin in melanocytes help to absorb heat and light and improve the optical function of the eye. So if you have a patient, for example, with ocular albinism, that's an inherited condition in which there is little or no melanin produced, they typically have very poor vision. So it's serving a useful purpose. And others have already discussed with a lot more scientific rigor the molecular events in progression, but essentially melanoma is caused by certain mutations which occur during the differentiation of the melanocyte over here. So you've had a talk already about GNAQ and 11 mutations. A very small proportion of nevi pass down another of these molecular pathways and differentiate into different types of uveal melanomas. What symptoms do people get? Well, typically patients can present with blurred vision. They can present with flashing sensations, new floaters. Part of the visual field goes missing. But as I've mentioned, up to a third of patients have no symptoms. So they're picked up on a screening examination. Here's an example of a patient who's a 45-year-old male who gets some flashes in his left eye for a week, and fortunately goes to see his optometrist, who dilates his pupil and finds this pigmented lesion just above the macula with subretinal fluid tracking down and causing some loss of visual field. One of the best known sufferers of uveal melanoma was the neurologist and author Oliver Sacks. He developed a uveal melanoma in 2006, and he quite memorably described experiencing loss of vision from one eye while he was at the movies. And he described his whole experience in his book, The Mind's Eye, about losing what it's like to lose stereoscopic vision. The next question I'm commonly asked is, how do you know it's a melanoma? Now, in the case of a skin melanoma, diagnosis is pretty easy. You take a biopsy and you can be certain of the diagnosis, but that's not as straightforward with uveal melanoma. And generally, our diagnosis is a clinical diagnosis. We can perform a biopsy, but that's not without certain risks, and it requires an operation. So most diagnoses are made on the basis of the clinical findings, the shape and the size and of the tumor, and on the results of multimodal imaging. It's worth pointing out that in the very large collaborative ocular melanoma study, which was performed over 10 years in the US and Canada, the rate of misdiagnosis was less than 0.5%. So we're generally fairly good at making that diagnosis. Now, not everyone who is referred to me has a melanoma. In fact, that's a much smaller proportion. And I think it's very important to make clear to patients that nevi are common. Up to 1 in 15 Caucasians in the Blue Mountains eye study have a choroidal nevus. So the great majority of patients referred to me do not have melanoma, they have a nevus. And choroidal melanoma is rare. In Perth, we see perhaps 20 or 25 new patients every year. Now, if nevi are common and melanomas are rare, what is the risk that a nevus can turn into a melanoma? Because we do think that most melanomas develop from pre-existing nevi. They develop a new mutation and transform. And that's been worked out. And statistically, it's about 1 in 8,000 risk, depending on your risk factors. Now, if you're much younger, then the risk is lower. And as you get older, that risk increases, and it increases also if you have certain risk factors, which we'll discuss, which we find when we're doing the examination. So there are certain clinical features of a tumor that make it more likely to transform into a melanoma. So a thicker tumor, a tumor that's got subretinal fluid, a tumor that's producing symptoms. They develop a kind of orange lipofuscin pigment on the surface, which shows up as on a picture called autofluorescence. And certain ultrasound features are more suggestive of melanoma than a nevus, although it can be difficult to tell the two apart. If the diagnosis is equivocal, as in this case on the left, we may offer the patient a biopsy, or we just may observe for signs of growth when we can be more confident about the diagnosis. Not uncommonly, I'm referred patients in whom an optometrist has noticed an increase in the size of a nevus, and this is potentially concerning, since we're taught during training that typically nevi do not increase in size. However, this study, which covered nearly 300 patients, show that almost a third of choroidal nevi do in fact get larger over time, and that's not necessarily a sign of transformation. So we have to be careful about making assumptions. So this is a patient who first presented to me in 2014. and he had what looked like a pretty simple choroidal nevus just above the macula in his right eye here. Easy to reassure him about that. However, he was able to produce photographs from his optometrist, which showed the picture 5 years previous to that, in which he had a much smaller lesion. So there's a clear documented increase in the size of this lesion, and that's concerning. However, we elected to observe him. It was very close to the macula. We didn't want to treat this, and since then it's stayed stable. 10 years on, there are no signs of malignant transformation. Now, once we made the diagnosis, how do we manage these patients? And the first thing I do is perform metastatic screening. So I send my patients either for a PET CT and or liver MRI. What we're looking for are signs of melanoma, typically in the liver. These tests are almost always negative, so we don't find metastases. It's only about 5% of patients have signs of metastatic disease at the time of their primary diagnosis, but we have to test for that. Now, the aim of treatment is to eliminate the primary. We think this is a primary eye tumor, of course, so we're trying to essentially turn off the tap. We're trying to kill all the melanoma cells in the eye. We know that the primary liberates circulating tumor cells, circulating tumor DNA, and we have to stop that process from occurring. Radiation is the primary treatment modality for this form of cancer. Enucleation is really the last resort for patients who can't be treated with radiotherapy. So our decision to treat and the modality of treatment depends on quite a few factors: the tumor location, the size of the tumor, whether the patient has any vision left, the age of the patient. We're unlikely to want to put a plaque onto a 95-year-old patient, even if they have a treatable melanoma. And obviously on their systemic status, are they otherwise healthy? If they have metastatic disease already, that will most likely impact our decision as to whether to treat them with local therapy. In Australia, by far the most common treatment modality for treating uveal melanoma is plaque brachytherapy. But in other countries, in Europe and the US, other forms of treatment are often preferred. So typically forms of external beam radiation. In Melbourne and Sydney, the linear accelerator is used. In Germany, the CyberKnife, and in UK and the US, sometimes proton beams. But for most of our patients, it's brachytherapy, and that comes from the Greek brachy, meaning short, and this refers to a form of radiation treatment where the sealed radiation source is placed inside or next to the area requiring treatment, so it's a short distance, hence brachytherapy. And the radioactive source we use is called a plaque. This is a patient in theatre, so the eye is being transilluminated by this light source up here, so we can see the outline of the tumor on the sclera by transilluminating the globe, and we can mark it, and then we can go and see exactly where the plaque is going to have to sit to treat this tumor. And the idea of the plaque is that it's sutured in place over the top of the melanoma. The plaque stays in place for typically 2 to 3 days, sometimes more, sometimes less. So that requires an operation to insert the plaque, as you heard this morning, and then another one to remove it. The iodine plaques, which we have to use sometimes for the larger tumors, are pretty bulky, uncomfortable plaques. Some of our plaques are 30 years old and more, but they still do the work. Iodine is a gamma emitter, so these plaques are used for the larger tumors because the gamma irradiation penetrates more deeply, and we can use these for tumors up to 10, sometimes even thicker, 12 or 13 millimeters thick. These plaques are individually made up for patients. In our center, we get the seeds, the radioactive iodine seeds from the US, and sometimes we have to order them, and there's a delay in that. The more commonly used plaque is ruthenium. So this would be worldwide, much more widely used. This is typically used for thinner tumors. It's a beta source. It is said to have less risk of collateral damage to the retina. So we typically use this for tumors up to 5 millimeters thick. And the advantage of this is that we buy one, it sits on the shelf, and we can just sterilize it and just reuse it over and over again. They're expensive, I believe about $50,000 per plaque. So we've only got one plaque in Perth that we use for all of our cases. Just moving now to prognostic biopsies, which Svetlana has covered in a lot more detail. So it's been known that although melanomas all look the same from the outside, they have different biological characteristics, and that information can be useful in predicting risk of metastatic disease. So a study performed right back in 1996 in Germany showed that the chromosomal copies of uveal melanoma cells, specifically loss or gain of certain chromosomes, could predict the behavior of the tumor and hence the future metastatic risk. So they performed a chromosomal analysis on 54 eyes that had been enucleated for uveal melanoma. And what they found was that if the tumor cells had only one copy of chromosome 3, and that's monosomy 3, then more than half of these patients went on to develop metastases. However, if the tumor had a normal complement, i.e. 2 copies of chromosome 3, none of them went on to get metastases. So this was a strong predictive factor. And since then, we know, as Svetlana outlined with her lovely slides, that chromosomes 1, 3, 6, and 8 are the main chromosomes that are important in prognosis. And that if you've got complete or partial loss of chromosome 3, the 5-year survival is less than 50%. So it's an important prognostic finding. Svetlana also mentioned gene expression profiling, and as she mentioned, this is a very expensive test. We don't have it in Australia. We can send samples on dry ice to the US, but that's not terribly practical. But if you are in the US, this is most likely the test that you would be offered, and you can see the survival probability for the different classes of tumors. So class 1A having the best survival with barely any mortality over a follow-up period here of 80 months, whereas the class 2B having the worst prognosis. So this is a patient of mine who had a prognostic biopsy and had a ruthenium plaque placed over that melanoma. This just gives a quick indication of how we go about performing the biopsy. This is done at the time of the plaque placement. So we use this instrument, which is called a vitrector, that the assistant is just loading up with a 3-way syringe tap. And you can see the vitrector here going into the tumor. This is a different patient to mine, but it's kind of like one of those puff balls that you see in the forest. So you rotate the little cutter and try to get a sample. They're tiny samples, and I have to pay tribute to our pathologists here in Perth, who are often able to get a diagnostic result with just such a tiny sample. And this is the same patient postoperatively. There's been a little bit of hemorrhage over the tumor, but generally a pretty good result. And I know David Sear last year at the AOMA meeting, he presented his data on the results of his tumor biopsies. So our results are very comparable to David. So we get a diagnostic or prognostic results, I should say, in about 80% of cases. In terms of follow-up, Generally, we become friends for life with our uveal melanoma patients. So we have to monitor the patients who've had plaque treatment initially every few months, and then hopefully as time goes by, we can push those appointment intervals out up to about a year. What we're looking for, obviously, are signs of the tumor starting to grow again, which is obviously something that we don't want to see. The other thing we monitor for is the complications of the radiotherapy. So I'm not going to go into this with this talk, but if you put a plaque on the eye, it causes some collateral damage to the retina, and patients may develop macular edema, needing some injections to stabilize their vision. The decision as to whether I involve an oncologist is largely up to the patients, but I certainly always recommend it if their prognostic biopsy comes back as showing that they're at increased risk. And I would say that most of my patients opt to be followed up by an oncologist, and I've got a very good good oncologist who happens to be in rooms immediately next door to mine, Tarek Meniawi, and he sees a lot of my patients, and he does the metastatic screening for them. So as an example of a patient who had a plaque placed, so he had this funny looking bilobular tumor just nasal to the optic disc in his left eye. So this was the pre-treatment image. And then you can see this is 3 years after treatment. So this is what we like to see, the tumor regressing. Fortunately, his tumor's in a favorable position vis-a-vis the macula. So he's at this stage managed to keep his vision, and his metastatic screening has been good. So he's doing very well. So I think that's where I'll finish my talk. If there are any questions, we will keep them to the end. So our next talk is going to be given by Jenny Geelen. So Jenny I work with closely. She's been making artificial eyes for nearly 30 years, along with her brother Paul and niece Emily. Jenny is a founding member of the Ocularists Association of Australia. In recent years, ocular melanoma has become the leading cause of eye loss in Perth, for which I think I'm responsible. The Geelens have developed a holistic approach to helping people through this difficult time. And it was one of the things I noticed from the earlier talks was that patients I can see in New Zealand and in the US are not fitted with a temporary prosthesis at the time of their enucleation. And I saw some of them having to wait months for this. Now, I removed a patient's eye on Thursday who had a melanoma, and Jenny had already sent along the temporary prosthesis, which we put in on the table, and the patient left with his prosthesis. So I think we're doing pretty well, Jenny, or you are.
Thanks,
congratulations.
Jenny. You've just about given half my talk. Hi, everybody. I'm Jenny. I work with my brother Paul and my niece Emily, and we're all Geelens, which can be a bit confusing at times. We see a vast array of patients, and they're from newborn to 105 years of age, and each of the eye prostheses are unique to each patient. They're all different size, different colour, different shape. So it's quite a vast array of people that we see. Ocular melanoma has become the most common cause of eye loss in WA. I don't know if that's the same the world around. I certainly don't see as many ocular melanoma cases in Darwin compared to other issues. So, and I think in other places, yeah, there's certainly Paul sees a lot more microphthalmia and ophthalmia. So it's just, yeah, in Perth, certainly it's certainly the more prevalent reason for eye loss. And we get a new case come through our office every week or two. So we do see a lot. And that doesn't include the ones that actually get diagnosed and treated for melanoma. It's only the ones that go on to have an eye removed that we see. So that's it's becoming quite common. Next slide, please. Paul and I are founding members of the Ocularist Association of Australia, and Emily's a member as well. There's only a dozen ocularists in Australia, and the association's a great support in quite an isolated industry. We don't sort of seem to sit in the parameters of any other job titles, so we are quite isolated, and we're all involved with training the next generation of ocularists. So, and we do get together quite regularly and give talks. So it's a good association to be with. Next slide, please. So I'm going to go through a quick run through of how we make an eye prosthesis. So first of all, there's an impression of the eye socket. So with this, we mix up an alginate, and we usually put that into a syringe. Sometimes we just put it in the back of the conformer shell and put that into the eye socket. It takes 30 seconds to a minute to set and gives us a good indication of what the eye socket's going to look like. So it's much like taking an impression of a mouth, well, like it used to be, because I think most mouth impressions are now done with 3D scans, and that's the way of the future for artificial eyes too. We are looking at perhaps getting 3D scanner in Perth eventually, and digital eyes will be a thing of the future. They're not quite there yet. Okay, so from the impression, we make that impression up into acrylic, and then we do the wax fit. It is called a wax fit because we used to make it up into wax and use that shape. We still use wax in shaping the acrylic just to get the eyelids sitting nicely, and we reduce and increase the size of it just to get everything sitting well, and get the iris into the shape as well, and get the alignment of that too, so that the eye is focused well. The third appointment is the paint of the eye. So we'll get the patient in for that and paint the eye while the person's sitting there. And to do that, we cut the top millimetre off the top of the prosthesis, off the front, and we paint on that surface, and then over that goes a clear acrylic layer, which brings all those paints to life and gives it a really lifelike effect. And then on the fourth visit, we've cured the acrylics, polished the eye up, we try it in. 90% of the time, there's an adjustment to be had, and so there'll be a final fit as well as we touch up any highlights in the paint, or maybe add a little bit more onto it, take some off. So that's and then there's always reviews as well. We always review an eye a couple of weeks afterwards to make sure it's settled in well, as every prosthesis is different, every eye socket as well, and so as the eye settles in, things change and we have to do fine adjustments. Next slide, please. So there's actually a lot more than 5 appointments to make an eye, especially when you're taking into consideration somebody who's about to lose an eye. So we'll make up a temporary eye prosthesis for them. Most people around the world just get a clear conformer shell, and it doesn't look so attractive and is quite disheartening for people to walk around like that for 6 to 8 weeks while everything settles. In America, the prostheses can be very expensive, and a lot of people go several years without an eye, while they try and battle with their pockets to get the funding together for an eye prosthesis. So we're quite lucky in Australia, whereas most prostheses are quite affordable, and people can get one pretty soon after surgery, if not before, with the temporary. So prior to 97 was the good year when we actually had a famous cricketer was in Sri Lanka on a test match. He closed one eye just by chance and noticed that the horizon was split, And he thought, oh, well, that's not good. So he arranged himself a few days off, flew back to Perth, went to the Lions Eye Institute, and was diagnosed with the melanoma. The next day he had the eye removed. In the meantime, we started making a temporary eye prosthesis, which was fitted on the Sunday. And then on Monday, he was back at work in Sri Lanka, no one the wiser. He didn't want anyone to know that he'd had an eye removed until the end of the test. So that was the first temporary eye prosthesis we made. And it looked so good, we thought, well, we should do this for everybody. And so we did. So everybody that gets a temporary prosthesis, the good thing is that people do come and see us then before they have an eye removed. We have time to talk them through the whole process, which a lot of people, a lot of doctors don't have time to sit down and do. A lot of patients would come to us and also say, my gosh, just told me they're taking my eye out and they've treated it like an ingrown toenail, they're really shocked. And it took me a while to sort of work out that actually there's probably no nice way to tell somebody they're going to have an eye removed. So, and by the time they've seen us, they've had a bit of time to digest the information, and we can go on with talking them through what's going to happen in the future and what to expect. And most people are quite pleasantly surprised. They think that a prosthesis is a round ball, like it's usually shown in movies like the Pirates of the Caribbean. And so they're quite pleasantly surprised that it's actually quite thin and small and does move with their other eye. So you can see in the photos, the middle photos of the temporary prosthesis there's a bit of hollowing under that top lip there. And that's because the temporary prosthesis is just a generic shape. We try and make it as close as possible, but we try to also make it a little bit smaller than the eye socket, so it's not putting any pressure on the suture line. And there's a lot of guesswork involved in that. So it just helps people to get on with life. And 95% of people, when they had their clear conformer, when they got the permanent prosthesis, they would burst into tears from relief from two months with the clear conformer. And we don't get that sort of result anymore. Nobody cries anymore. They come out of surgery with a temporary prosthesis and they get the permanent prosthesis 8 weeks later, and everybody's happy. There's no more tears, which is fantastic. It's a big revelation, and we do try and encourage ocularists around the world to take up the practice of making temporary prostheses, and if you have, hopefully more will get into it as time goes by. Next slide, please. So we worked out at the time, back in '97, that there really was very little in the way of resources for people about to lose an eye. So we put together this mind map with the help of a psychologist and a few of our patients. You can see there's a few different branches on the mind map: the operation itself, appointments to make a prosthesis, people who play sports, what they can expect from that, accepting your eye, and so on. So we put this together and had it printed up so that when people came in to see us the first time, we could run them through all the different aspects of it and then give them a copy of the mind map to take home with them, just to jog their memory on what's happening. When somebody's faced with a traumatic event, 70% of their brain space capacity is taken up with the emotional side of the event, and people very rarely remember more than 30% of anything they're told. So having a visual cue like the mind map was a perfect way of helping people to remember what's coming up. So from the mind map, we started our first website, Geelen.com, which was centred around our West Australia business, and did feature the mind map, and you could click on the branches of the mind map and get all the information that we talked about in the appointment. So on to the next slide, please. So not long after that, we thought, well, it's a good website for artificial eyes and our home group. but we thought we'd really like to get information out to the rest of the world. And so we did develop artificialeyes.net. There is a feature on the middle line, which is find an ocularist. We have many of the ocularists around the world featured on that, so that people can find an ocularist. We tend to be a very hard creature to find, so having a resource like that is fantastic for patients. There's also other resources on there: stories, brochure on maintenance, how to look after the eye, and other things. Okay, next slide, please. We're very lucky. One of our patients, Anne Trigg, she started a ocular melanoma support group in West Australia several years ago now, and she has first-hand experience of having an eye removed, so she's a good person to run that group. They meet once a month or so for coffee, and I believe they're also involved in some research projects as well, which is fantastic. I give all of my patients who have ocular melanoma, I give them a little flyer so that they've got that support there if they need it. Next slide, please. This is a book we wrote, must be a dozen years ago now, A Different Perspective. It's written especially for people who are about to have an eye removed. So it's available as an ebook, and also in paperback, which you can order through our website. There's a lot of white space in the front of the book and lots of dot point. This is because people don't have the capacity to take in a lot when they're faced with that traumatic event. So it's very easy to follow, no graphic pictures or anything like that. Just very easy. A few stories in the middle of the book, and then there's also lots more information in the back of the book when people are ready to digest a bit more. Next slide, please. Paul's been working on a series of videos. He's got 4 in all so far. First of all, there's the monocular vision, then appointments to make your new eye prosthesis. The third one is maintenance of an artificial eye. And the fourth one, the operation and what to expect. He's working on doing a few more videos, so there will be more in this space in the future. These videos are all available on YouTube and through a link on our website as well. There's more to come with that. Next slide, please. This is Val. We do get to know people very well. She lost her eye 24 years ago to melanoma, and she's just gets on with life. She's nobody likes to have lost an eye, you know, and she doesn't like to have lost it either, but she's pretty happy that she can still get around, and she's alive to enjoy family and friends and all of her bits in life to enjoy. We do get to know people very, very well. There's more than just the 5 appointments to make the eye. There is about 12 in all, in fact. 2 for the temporary, usually a couple of adjustments in the first 8 weeks while everything settles down. There's the 5 appointments to make the new eye. There's a couple of appointments.
1 minute, thanks.
A couple of weeks afterwards.
Jenny?
Sorry?
1 minute, thank you.
Oh, thank you. Yeah, a couple of appointments to adjust the final prosthesis, and then a final review after 3 months, just so everything's settled in and looking natural. We get to know people very well, and so over the time we have lost a few friends along the way, but there's also people like Val who've lived 20, 30, 40 years post melanoma and still getting on. It's fantastic. Next slide, please. I just thank you for listening. I hope anyone facing eye loss has a clearer picture of what to expect. And you can contact me by email anytime. I'm happy to answer any questions anytime. Thank you.
Thank you, Jenny. That was very informative.
Thanks,
and we're just going to move to our final speaker for this session. So our next speaker is Illyana Klevansky. So Illyana is actually one of my patients who's very generously agreed to share her story. I'll leave her to tell her own tale. She's based her talk on contemporaneous notes she took during the time that she was going through this traumatic event. Illyana, how are you?
Hi, I'm well, thank you. Can you see me, hear me?
Yes,
Should I
yes, we can.
start?
Thank you. Go for
Okay.
it.
My presentation is called Seeing the Light, and hello, everyone. My name is Illyana Klevansky, and I live in Perth, Western Australia. I'm a freelance writer, and 3 years ago, I was advised to have my eye enucleated. Well, the news was so traumatic. I began dealing with it in the way that I usually deal with things, and that is to write down my thoughts and fears. So I started a journal, and this presentation chronicles the events leading up to and including my post-operative experience along this life-changing journey. And please forgive me for reading my notes, which I wrote at the time. 10th of February to the 11th of June, 2021. It began in February when I had my annual checkup at Specsavers. The optometrist, whom I'd seen previously, showed me photos of my eye over the previous couple of years. And she pointed out that there was a tiny freckle in my right eye, a little freckle, a nevus, so benign. But at this latest visit, she shocked me by telling me that something serious was happening and that I needed to urgently consult an ophthalmic specialist, as I could have an ocular melanoma on the rim of my optic nerve. What? There and then, she referred me to Dr. Tim Isaacs at the Perth Retina Clinic, and a couple of days later, I had an appointment. I feel like all my senses have shut down. I cannot believe it. I had my first consult today with Dr. Isaacs, who wants to run a few more tests, as well as giving me some time to digest all this information. And he discussed experiences of other patients who, like me, desperately hoped to hang on to binocular vision. But he explained that the possibility with an ocular melanoma such as this, I have very few options ahead. The most drastic and the only way to prevent the cancer from spreading is to remove my right eye. Yes. I'm senseless. I cannot describe my terror. I'm blindsided. I feel that I'm in a dark tunnel and I don't see any light ahead. I have cancer and I just have to face it. Dr. Isaacs referred me to Artificial Eye Services, and I've now met with Jenny Paul and Emily Geelen. They've assured me that they'll make me a temporary prosthetic, which will be inserted during the surgery, and then after a few weeks, they'll manufacture a more permanent prosthetic molded to fit my eye socket, which will give me greater confidence. 14th of June, 2021. I'm immobilized. It's just too big to comprehend. The operation looms, and I'm feeling very fragile and fragmented. Today was my final consult with Dr. Isaacs, and I have to say, he was very kind and very careful with me because he realizes that I'm just so anxious about what lies ahead. And I do know that I'm very lucky to have him to give me as much information as possible. And look, at the end of the day, he's trying to save my life. I'm doing everything automatically. I'm treading water in a state of suspended animation. I cannot speak to anyone around me because my fear is crystallized into silence. And I don't know anyone or have contact with anyone who's actually been through this. This time, next Friday, I'll only have one eye, but I won't have cancer. And I'm terrified because this is my new reality, disfigured, distraught. I'm diffused with sadness. I'm consumed with fear. I keep trying to think ahead, and now I worry how my world would look. I wish I could go back. I've got regrets and memories. My wonderful husband, Ian, and I, we lie awake at night and we don't dare voice our fears to each other, but I know what he's thinking. I keep looking at my eyes in the magnifying mirror and they look perfect, blue, brilliant, deadly. And I keep thinking of everything that I need to do with both eyes, books to read and stories to write and things and movies to see. How will I look? Will I be able to look at my half face? It's just very confrontational. And will those around me look at me and recoil? I've had many health issues over the years. I've had a melanoma on my scalp, a melanoma on my leg, and now I have a melanoma growing inside my eye. And each time I've bounced back. But this time I don't feel very strong. I have to keep reminding myself I'm not a victim. I'm simply so sad, and I don't want to wake up next Friday to face what has happened to my face. I don't know how to be calm. I've rationalized my fear, 15th of June 2021, into 3 areas. I have cancer, and that's huge to deal with. I'm going to have one eye with which to see, and that's daunting because this is for the rest of my life. I'll be disfigured, and my new face will look very different to my previous face. So these last few days before surgery, I'm taking photos of my eyes so that I can remember how I used to look. I look so normal, and yet I have deadly cells growing inside me. And I keep thinking, this time, next Saturday, I won't have my right eye. How could I ever accede to having my eye cut out of my face? 21st of June, 2021. It's over. I'm home with no pain. It's quite strange because I've had to accept that my eye is gone, but I'm so relieved that I don't have cancer anymore. 8th of July, 2021. Nearly 3 surreal weeks later with only one eye. And I keep reminding myself that this was done to give me a second chance. My bruises are healing. Next week, artificial eye services will fit me with my new made-to-measure eye. And with each visit to the Geelens, as confronting as it is to force myself to look at my unfamiliar new self, it's amazing to watch how professional they are in the way that they're looking at every color striation in my left eye. 2nd of February, 2022. It's my 70th birthday. What a year this has been. But I'm healthy. I'm trusting my own tuition. I'm learning to use that my left eye is compensating for whatever I used to do with binocular vision. And now, after 6 months, I've actually started driving again, very cautiously. However, it has taken a long time for me to look at myself in my mirror with my new eye. I still cannot reconcile the visual ruin of my right eye, but I'm presenting my new face to the world, and friends come up to me and they look at me and they try and determine which eye looks different. This artificial eye is very comfortable, perfectly color matched to my left eye, and that of course is due to the artistry of the Geelens. 12th of May 2024. On the 12th of May 2023 last year, I suffered an aortic dissection requiring emergency cardiac surgery, and then I had 2 small strokes. I'm still not allowed to drive, but that's a minor setback. The best news of all, after worrying about the health of my heart and my brain, I never think about losing my right eye. After 3 years, I've come from a drastic diagnosis to the light of living. I now have PET scans every 6 months. I'm very comfortable with monocular vision, and I'm so grateful that I have been given 2 life-saving chances to live with my wonderful Ian, my children, my grandchildren, and I would like to thank everyone who is still involved in safeguarding my health. I need to express my everlasting thanks the incredible support given to me by Dr. Tim Isaacs, by Jenny Paul and Emily Geelen. Between this team, my ocular melanoma was handled with complete professionalism and kindness as they guided me through the darkness of my trauma to seeing the light. And I would like to thank AOMA for inviting me and for Dr. Tim to present this today. Thank you.
Well, thank you so much, Illyana. That is a very moving story, and thank you for being so honest and sharing it. I think we're all very moved by what you've had to say, and I'm sorry you had to go through it, but you're a very brave lady. So I'm sorry, I think I've run out of time. That was largely my fault for overrunning my own presentation, so I apologize to that. So we haven't got time for the Q&A.